Extract a living heart from a vertebrate, place it on a sterile tray, and it will continue to beat. It requires no instructions from the brain. The vertebrate heart is myogenic, meaning the tissue itself generates the electrical spark required for contraction. In a healthy human adult at rest, this localized electrical firing happens about 72 times per minute. That dictates a highly precise, repeating sequence lasting exactly 0.8 seconds. In the span of 1 minute, those rapid 0.8-second cycles propel roughly 5.4 liters of blood through the circulatory system. To understand how an organ sustains that massive continuous output, we have to look past the anatomy of a simple muscle. We need to analyze the heart as a finely tuned electromechanical fluid pump. Clinicians rely on 3 main surface diagnostics to inspect this pump without opening the chest cavity: electrical tracking, acoustic monitoring, and pressure readouts. This chart shows an electrocardiogram, or ECG. It captures a repeating signature of voltage changes, labeled as the P, QRS, and T waves. By aligning that trace with an acoustic phonocardiogram, we see the familiar lub-dub sounds map exactly to these electrical spikes. Together with a standard blood pressure reading, these surface signals paint a complete picture of the machine's internal mechanics. By stepping chronologically through a single 0.8-second cycle, we can map exactly how a localized electrical impulse translates into sheer mechanical pressure. This diagram shows the internal wiring of the heart. At time 0.0 seconds, the cycle begins here, at the sino-auricular, or SA node, located in the wall of the right auricle. The SA node contains specialized muscle fibers with a natural, constant leakage of sodium ions. This leakage steadily drops their resting electrical potential to about -50 millivolts, forcing the cells to self-excite. That spontaneous electrochemical spark causes the upper chambers to contract. On our surface monitor, this is the origin of the P wave. The electrical signal then moves down to a secondary cluster called the atrioventricular, or AV node. Here, conduction velocity plummets. The signal slows to a crawl of just 0.05 meters per second. This 0.1 second delay is an engineered anatomical bottleneck. It ensures the upper chambers finish squeezing all their blood into the ventricles below before those lower chambers are allowed to fire. Exiting the AV node, the signal races down a thick band of muscle fibers along the central septum, known as the bundle of His. Hitting the branching Purkinje fibers along the outer ventricular walls, velocity shifts violently, accelerating to 4.0 meters per second. This rapid bottom-up electrical spread triggers a massive depolarization in the ventricles, registering on our ECG monitor as the sharp QRS complex. This animated graph illustrates the immediate mechanical result, a 0.05-second window called isovolumetric contraction. The ventricles flex hard, but all the exit valves remain securely closed. Notice that the volume of blood doesn't change yet. The muscle fibers are not physically shortening, they are simply building immense internal tension. This coordinated electrical lightning strike generates the instantaneous high pressure necessary to force fluid through the entire systemic circuit. This cross-section details the valve architecture. As the rising pressure inside the ventricles rapidly exceeds the pressure in the upper chambers, the tricuspid and bicuspid valves slam shut to prevent backflow. The physical vibration of those massive valves snapping closed creates the first acoustic heart sound. This is the lub in the stethoscope. The cycle now enters a 0.25-second ejection phase. The mounting pressure blasts the semilunar valves open, forcing blood up into the aorta and the pulmonary artery. Following ejection, the ventricles begin to relax, a phase called diastole, marked by the T wave. As the muscle tension drops, the ejected blood attempts to flow backward, which violently catches and slams the semilunar valves shut. That second impact generates the higher-pitched dup sound. This cyclic diagram maps the exact timing of these events. The ventricles spend just 0.3 seconds in active systole and a full 0.5 seconds in diastole, relaxing and refilling with blood. Because of this tightly regimented electromechanical timing, a healthy human heart actually spends the vast majority of its life resting. We can quantify this performance by calculating cardiac output. The stroke volume, or the amount of blood pumped per beat, multiplied by the heart rate. At rest, that equation yields 5 to 5.5 liters of blood per minute. But this creates a physiological problem. If the SA node runs on a fixed myogenic autopilot, the heart cannot instinctively know when the body is exercising and requires more oxygen. This schematic isolates the neural override system. The brain maintains regulatory control via the vasomotor center in the medulla oblongata. When metabolic demands increase, the sympathetic nervous system acts as an accelerator. It releases hormones like adrenaline that increase sodium permeability in the SA node, accelerating the electrical spark. Conversely, the vagus nerve acts as the parasympathetic brake, inhibiting that discharge rate to slow the system down. The heart's internal rhythm operates in a continuous second-by-second tug-of-war with the autonomic nervous system to perfectly match the body's varying demands. This common diagnostic tool, the sphygmomanometer, provides the ultimate clinical measure of this entire system's efficiency. A classic reading of 120/80 encapsulates the two extremes of the cycle. The top number, the systolic pressure of 120, marks the absolute maximum force exerted against the arterial walls during that violent QRS ejection phase. The bottom number, the diastolic pressure of 80, represents the baseline tension remaining in the arteries during the long 0.5-second relaxation phase. We started with 3 surface diagnostics: the electrical waves of an ECG, the acoustic thuds in a stethoscope, and the pressure of a cuff. Every fluctuation on a monitor and every physical pulse is simply a direct, measurable echo of this relentless, beautifully engineered 0.8-second loop.